Elvis is the project coordinator and community palliative care director at the Uzima project at Ndanda in Tanzania, and first came to work with us as part of the Southeast Tanzania project. Have we got Elvis?
Hello, good afternoon.
Hello, Elvis, you're very welcome, please. Over to you.
Yes, thank you. I was wondering, do you have my pre-recorded presentation? Because I have some issues with my internet, I believe.
Welcome, viewers. This is Elvis Miti, a student at Calcutta University, doing a PhD in public health. I'm going to present you with a research protocol on outcome evaluation of palliative care works of UK training videos for healthcare professionals, a multi-hospital quasi-experimental study in southeastern Tanzania. You are all welcome. Statement of the problem. The requirement to evaluate the outcome of new training items is evident in various medical training fields globally. Palliative Care Works of UK launched their 5 videos, herein referred to as 5 PCWF, at the end of 2021. There is no evidence of any evaluation or publication to determine the 5 PCWF outcomes regarding change in HCP's interest in learning of palliative care in Tanzania. The main purpose of this study is to do a rigorous outcome evaluation of the 5 PCWF as a pedagogy, and we want to ensure that the HCPs have got best quality training, and as we strive to meet the rising demand for palliative care services among our patients, we're going to use the mixed method that we're going to collect qualitative and quantitative data, and we're going to, as already said, this will be a quasi-experimental study, not a random controlled trial because of geographical reasons. The 4 healthcare services are about 200 kilometers apart, and we're going to use the Patrick's constructs in evaluating using the 2 first levels, that is the reaction and learning, and we expect to do focused group discussions to 10 to 15 participants, and we expect maybe 50% from the experimental and 50% from the comparative groups. We expect to recruit those people who have not done any training in palliative care, and at the facilities, working at the facilities that we are going to do the research, and we estimate we're going to have at around 256 participants, of which 65 will come from each, about 64 will come from each institution. Research questions according to Kirkpatrick's levels 1 and 2 are reaction of the trainees. What is the HCP trainees' reaction to the 5 PCWF? Learning in the training process, what did the HCPs learn from the 5 PCW content? The hypotheses are, the new hypothesis is there is no relationship between using the 5 PCWF and HPC learning basic PC knowledge and skills, and alternative hypothesis, there is a relationship between using the 5 PCWF and HPC learning basic skills in palliative care. Data collection tools. We're going to use the mixed method to facilitate triangulation, qualitative data collection, open-ended questionnaires, FDDs, and observations. Quantitative data collection, we're going to use closed-ended questionnaires. Data analysis, we're going to use SPSS for quantitative data analysis. Statistical inference, descriptive analysis will include a square test. a paired t-test and an independent sample t-test to test for correlation. The researcher will accept a significant level of p-value of equal to or more than 0.05. We're going to use in vivo to analyze our qualitative data and so that we can find some imaging views and come up with themes from the participants. Sampling method, we're going to use MMS, and this will be a concurrent MMS in each of the facilities, and MMS is good because it gives us room for creativity, especially working in a busy environment of healthcare professionals. Depending on the particular health facilities, the researcher may need to use purposive sampling for the intervention and comparative group, and use cluster sampling for FGDs if there is any homogeneity groups at the health facilities. The researcher will take advantage of the health facilities setting to make necessary observation for and for SIMS data sources. Location in southeastern Tanzania, in Lindi region, and in Mtwara. In Lindi, there's Sokoine Regional Hospital and Ligura Referral Hospital, and Lubeg St. Nyangao Hospital, and in Mtwara, there's St. Benedict's Referral Hospital. Ethical consideration, we're going to use the WMA Declaration of Helsinki Principles of Ethics. And in this study, no drugs will be used, and no patient may be used in this study. And the healthcare providers will sign a consent form, and they'll be free to continue or to stop any time during the study. And they're going to get permission from the health facilities and from Palliative Care Works of UK. And we're going to seek clearance from UNICAF University, Zambia, and National Medical Research Institute in Tanzania. We have quite a number of references, and you're most welcome. And thank you for listening, and I hope you enjoyed my presentation. Thank you.
Yes, I can hear you. I can hear you. Thank you. Thank you so much.
No, thank you very much indeed, Elvis, and we wish you well with your research and with your studies, and we're hoping that you'll stay online because there may be some questions a little bit later on, but we're going to move on if that's all right with you, and ask Marie Rose Intagura, who's a very long-standing friend of ours in Zambia. I had the privilege of working with her in Zambia some years ago. And she has, over the course of time, and it has taken time, has developed this wonderful palliative care team there. And we've asked her to talk about her latest venture, which is delivering home-based care to the local community far from her hospital in Mazabuka.
Good afternoon, everyone. Rose Ntigura from Mazabuka, Zambia, and I'm sharing with you how we support to those most in need. I work in Mazabuka, situated in the southern province of Zambia, and this hospital serves a catchment population of 219 people. It is a referral hospital, a second level hospital. In fact, it is a hospital special meant for specialties. Being a high volume facility, the majority of palliative care cases are sent to the hospital, the only place, in fact, that you can find in the area. Reaching out, where should we start from? It is first an acknowledgement of the available opportunities, since it was starting from scratch, and I needed to find people who were willing to do something, and to use the available structures. In this case, we had some home-based care centers, and then acknowledging the gaps. In fact, we don't have palliative care policies in this country. We don't have enough trained personnel at all levels. In the hospital where I am, we have morphine available at all time. And it is being well prescribed and used. So then, where do we start from? I have started by identifying influential individuals around me, the medical superintendent, for example, the chief pharmacist, the wards in charges, the local dominant church leaders, and other people. And then I conceived two principles who helped me to go forward. The first one is the tortoise race principle. Like in whatever things I did and I'm doing, I need to go slowly, but surely. And I made sure that I leave some footprint behind me. There's no need to fly when you know that you are leaving nothing behind you, that you didn't even make any change or add some quality in someone's life. So then there is also the principle of the chameleon, camouflage, not to harm, but to be part of what is going on, to be part of the people that you are saving, to be part of their sorrows, their questionings, to stand where they cry, to be there, to blend in with the environment, to be one of them, to do everything you can to help him or her live before they die, as Dame Cicely Sanders said. So then you are ready to go, adding some lives in their days. Yeah, you meet them where they are. Like this picture is showing us, we had gone in a rural health center, and then we found those people with different needs. And we carry with us some drugs, some clothes, some foodstuffs, and our touches and our smiles, and we meet them. Even if they are children, in different ways, they will tell you their stories. Be attentive and patient. You shall know what is their pain or what are their needs, even if they're children. The problem we hear is that the children are meant to be seen, not to be heard. And if a child has a terminal illness, it is rare, it is difficult for that child to access medical services. Generally, unless the carer or the guardians is being disturbed by the condition of the child. Otherwise, it is seen like maybe it is witchcraft, or maybe it is a spell, or it is something. But with sensitizations, a lot of radio programs, a lot of outreach programs, we are getting somewhere. We are meeting everyone. No one should be left behind. So we also meet them in their places, at home, where they are, and we share what we have. And most of the times we are surprised. They share what they have. And then life goes on and we continue. Then this is our team. And it is not easy because the palliative care is not yet in the civil service. Whoever is working as a palliative care provider, it is on a voluntary basis, along with other activities that you have. But this picture here, it shows an outreach which happened some 67 kilometers away from Mazabuka, our town. And we always use our own resources to reach out to people. And this team was composed by, on the right side, a retired midwife who's coordinating the home-based care where we were. And then behind her, there is a young medical officer using her free time. Then on the left side behind, a registered nurse, and then a physiotherapist. Yeah, yes, the only specialized with in palliative care. So this is how we do it, and no one should be left behind. Palliative care is for everyone. At a certain point, everyone might need it. So our motto is to make your bed in the morning, because you don't know how the night will come. It shall find you your bed ready, meaning that we need to do everything to set palliative care services accessible and available to everyone, because you never know who's going to need it next. Thank you.
Mary Rose, are you there? Can you
Yes,
hear me,
I
Mary?
am.
Hi, Mary
Yes,
Rose,
good
thank you.
afternoon.
It's lovely to hear you, lovely to see the work that you're doing. It's brilliant, Mary Rose. We commend and salute you for what you're doing. You've struggled over many, many years. And one of the themes that we've been addressing today is the time it takes to go from the idea to actually what you're doing, which is delivering much needed care to lots of vulnerable people in your area. So thank you for that. If you stay online, there may be questions a little later. But we're now going to move to, is that all right, Mary Rose? We'll speak to you later. Okay, bye.
Okay, thank you.
Thank you. So Tamer is a long-standing colleague. First met Karen, I think you met Tamer first, didn't you?
I think Joe did. Yeah.
So he's a Palestinian nurse. He's the first nurse prescriber appointed in Palestine. And we met him when we were part of a training program for oncology nurses in Bethlehem. This is an online one. He's not able to join us because he's working, but he's sent in this pre-recorded message, which does show some distressing images.
Hello everyone. So my name is Tamer Al-Jafari. I am working currently in Bethlehem Care Hospice and the Trust in Palestine in home-based palliative care. Actually, this work started since July 2023 as we met before in this conference and we talked about nursing in Palestine. This is an article which was published in July 2023 in the International Journal for Advancing Practice about the initiation of a non-medical prescriber from nursing background. That was an article, I published it, and actually I got a help from a colleague of me. His name is Matthew Fowler. Then I would like to update about our work. Currently, we are working newly in the home-based palliative care. This is my team. My team here I am on the left side, and I have 5 nurses with me, working with me, social workers. I have psychologists and occupational therapists, physiotherapists. They are all working together with us. So that's what we are doing, and we are looking forward to increase our team members to make it to be 3 teams of nurses to work every day. Currently, we are doing 8 visits per day, 2 teams. Each team are doing 4 visits per day. So currently, as you see here, since July 2023, since we started, we had worked with 129 cases. So we underwent 1,690 93 visits. As another update about our work in Palestine, in Bethlehem, We are currently working in Bethlehem. As you see, this is a car, got a gunshot while it was I was parking it in front of my house. This is my car, which I use it to do the palliative care visits. So we are currently working in a conflict zone, in an ongoing war, in a high-risk area, even a high risk on the employees themselves. We have a medication shortage, such as narcotics and other medications. So sometimes we need to use this medication, but we found that there is no availability of this medication. This is the current situation here in Palestine and in Bethlehem. There is a financial crisis for patients and their families. Many of people here had lost their jobs, and the financial situation is going down and down. People cannot buy their own medications because the government here cannot pay for the bills, and they cannot offer all the pills, such as they cannot offer Clexane or anticoagulant such as Apixaban, and the families have to pay for it. But many families starving, they only focusing about how to buy their own food. So we are still prescribing medication, and the available medications, that's what we are prescribing it. And this is a picture of some donations we got it, and we prescribe medications according to what donations we have in our center. And many times I coordinate with other hospitals and physicians according to any patient situation. We are increasing the access and trying to support and help any patient with palliative care needs in Palestine. Previously, we get used to say that there is no access to palliative care. 1 year ago or 2 years ago, we said that there is a limited access to palliative care, but currently I say that we are increasing the access, and we are offering our service for everyone in Palestine, even if by phone call, and we are trying to visit everyone with palliative care needs in Bethlehem, in this city, and we are looking forward to make this service can reach anyone in Palestine, even to Gaza. So what we will do next, we will continue, we will keep our resilience, we will fight until the last breath. I'm gonna get my PhD to do more and more and more, and we are going to do more researches. Thank you very much.
I'm delighted to welcome Dr. Frederica Collins, who is joining us for the first time. We haven't met Frederica, but you're very welcome. And you're going to talk to us a little bit about your experience as a volunteer in Ethiopia, I guess.
Yeah, thank you so much for having me.
Oh, thank you.
Can I share my screen? How does it work? Okay, apologies about that. So yeah, my name is Freddie. I'm a internal medicine final year trainee hoping to apply to palliative care this year. And I'm also a trustee of Hospice Ethiopia UK, which is a charity in the UK which aims to fundraise for a community-based palliative care service in Ethiopia. So the past 2 years, I've been working as an internist at a hospital in Addis Ababa, and also volunteering at Hospice Ethiopia during my time there, where I did an audit looking at the sort of burden of pain in the cohort of patients in that community service, and also looking at that access to oral morphine. So thank you so much for giving me the opportunity to present today. This is my first time at Palliative Care Works conference, and I've had a fantastic day, so thank you so much. So as everyone's probably seen this diagram from the Lancet 2018 Commission report before, but as we know, there's a morphine access divide globally, as we just heard in the previous talk as well. So 50% of the global population receive less than 1% of the global morphine supply. And as we can see in places like North America, especially, there's this very bloated supply of morphine, which actually tips over into opioid addiction, causing excess deaths in that part of the world. Whereas the rest of the 50% of the global population don't have access to morphine really at all. And especially in Ethiopia, this is a sort of double-edged sword where there isn't a supply of morphine because of multiple issues such as bureaucracy, red tape, difficulties importing due to the cost of the birr against the dollar. But also, even when there is a supply of morphine, there's great hesitancy about prescribing it due to fears of addiction, side effects, and death. And some of that is driven by that opioid crisis in the Western world. 80% of patients globally who are in great need of palliative care are found in lower middle income countries such as Ethiopia, where this scarcity of morphine exists. So it's a real problem. And as we also know from the WHO, 80% of patients with terminal illnesses are experiencing moderate to severe pain at the end of their lives. So there's this very high need for effective analgesia. So this audit aimed to determine the burden of uncontrolled pain in Hospice Ethiopia's cohort and also that access to oral morphine. So Hospice Ethiopia is a small community-based palliative care service. It doesn't have any inpatient beds, it's all home care. It's actually celebrating its 20th anniversary this year. Looks after about 300 patients at the moment and has 3 full-time paid nurses and a volunteer doctor who mainly does prescriptions. It's fully funded through donations with no government support at the moment. Alongside their clinical work, they also are involved with trying to get palliative care into the national curriculum and do training at hospitals, both within the capital, but also in different regions of the country. Ethiopia has a population of 120 million, and the palliative care service in Ethiopia has only really been starting up over the past decade or so. But there are some exciting moves going on at the moment. With the service expanding, although resources are very limited for that to happen. Another area they tried to get involved with is policy. So most notably at the moment, the charity is working with the Ethiopian government trying to set up their first national morphine production unit, which will be set up in the government, if it goes through, will be set up in the main government hospital in Addis. So this audit looked at 100 charts of deceased patients who had either a diagnosis of HIV or cancer. The average age of the patient in the audit was 52, with more women than men. They had high social deprivation, with 45% of patients earning less than £2 a month, and over 2/3 of patients not having no or primary only level of education. In a country with no social support, obviously the role of the family is very important, and 88% of patients were being supported by their family. But as we heard earlier, that's an issue in itself, because often families will get themselves into great debt trying to save a dying family member who either they haven't been told the correct diagnosis for, that it's terminal, or so they're continuing trying to investigate and pay for expensive treatments, when what that patient really needs is effective palliative care, which would not only help that patient, but also financially help the family. So in terms of the audit results, so 95% of cancer patients reported pain, 91% of patients with HIV reported pain, and 100% of patients with HIV and cancer reported pain. The average pain severity scoring on their first assessment visit by Hospice Ethiopia was 3.85 out of 5. And on their first visit, only 5% of patients said that their pain was controlled. By Hospice Ethiopia's final visit before they died, 60% of patients reported that their pain was controlled, which obviously shows how effective Hospice Ethiopia's interventions are, but it does also reveal the unmet need there, with 40% still not having their pain controlled. Over half of patients never had any access to oral morphine, and 15% of patients had intermittent access, which can sometimes be more difficult for the patient because they swing between having their pain controlled and then not controlled, which can be psychologically very traumatic. And in more recent years, the proportion has changed. So morphine access has become less in more recent years, and that's because of the war in Ethiopia, also rising inflation, but also because one of the producers of morphine is morphine is no longer supplying to the country, so it's more difficult to access morphine in more recent years. So before Hospice Ethiopia saw patients, over a third of patients weren't taking any analgesia at all, and you can see the spread of patients who were taking other all sorts of medications such as ibuprofen, neuropathic pain medications, and weak opioids. And then after Hospice Ethiopia intervened, you can see that only about 5 patients are not having any analgesia, and they're using the tools that Hospice Ethiopia used to control pain is basically, as I said, neuropathic pain medications and non-steroidals. I also looked at the burden of other symptoms alongside pain, and you can see the most common symptoms are similar to what we see here in the UK. So alongside psychological and spiritual issues, anorexia, constipation, sleep disturbance, nausea and vomiting, dyspepsia. So in conclusion, 95% of Hospice Ethiopia's patients experience pain, which is above the WHO's estimate of 80% of patients at the end of their life experiencing pain. Hospice Ethiopia's interventions do improve pain control, and that's with very limited resources, so using just tablet analgesia, psychological and spiritual support. So it's a massive testament to the work that they're doing, that they're able to have that massive an impact on their pain control. But as we can see, there is still a high and unmet need. And the talk that we had earlier, the fantastic talk earlier, talking about the desperate need for universal health coverage, would be essential to meet this demand. And we need to make sure that that universal health coverage includes palliative care and obviously the provision of cost-effective, cheap oral morphine. So there's hopes that Ethiopia's morphine production unit will go some way to address this need, but it does need to have proper regulation and proper distribution of the morphine, and obviously be free to access for the patients, and going to patients with terminal illnesses, because it will be under national control. There's no safeguarding in initial plans at the moment that it will go obviously to patients, to palliative patients, as opposed to other patients who will need it, for example, in surgical departments. And I think that was everything. Thank you so much. Sorry, I've just come off a week of night shifts. I'm sorry if I don't make sense all the time. Thank you very much.
No, thank you very much indeed. You made complete sense, and you're very
I kept losing
impressive.
my train of thought, sorry.
No, you didn't. There was no sign of that at all. Thank you very much indeed. And congratulations on the audit, and we wish you well in your training, because people like you are the future of palliative care, both here and abroad. So congratulations, and keep in touch, please.
Thank you so much. Thank you.
Thank you. And so we're very pleased to say that SNM is online. Is that right? SNM, are you there? SNM and Pico is a long-standing friend who I think you first talked to in Ghana. SNM, hello.
Hello.
How are you?
Hi, can you hear me?
Yeah, loud and clear, and we can see you too. Looking very well.
Hello.
Hello, can you hear us, SNM?
Yes, I can hear you clearly.
Good. You're very welcome. We're really delighted that you're able to join us, and we're looking forward to.
Yes, I'm so happy I was able to make it.
Yeah, so are we. So are we. So over to you, SNM.
Yeah, I mean, unfortunately, I don't have slides to share, but my intention was to share with you what's going on in Ghana now and what I'm doing as well in my hospital. My name is Anita Isinamagbeko. I'm a general surgeon. I work in Komfanochi Teaching Hospital in Ghana, in Kumasi. That's more like in the middle belt of the country. And well, my palliative care journey probably started sometime in 2012. A good part of my initial training had been with Palliative Care Works, and we've been in touch since then. So, I mean, with regards to what's going on with me now, probably I was going to talk about it in 2 parts, at a national level and at a local level. So at the national level, I mean, this year celebrating palliative care this October, I would say that in the course of the whole year, our National Palliative Care Association has really made, should I say, great strides. And as part of this year's celebration, we started looking at really putting down a national strategic plan for ourselves and looking at areas of training, accreditation, financing, research, advocacy, and being able to really document what is going on in palliative care in the country, because we realize there are lots of pockets and people doing things that we don't, should I say, have as a cohesive thing. And so being able to document all that was going to be helpful. We've had more people going to palliative care training at the doctor's level, at the Ghana College, the Postgraduate Medical Training College. There's a fellowship program now for palliative care. And I think there are up to about 5 people in training now. Others have graduated. And then the nursing college also has a postgraduate fellowship for palliative care. And my hospital alone has got about 3 graduates and others who are still in training. And the exciting thing about this is, I mean, people train and move to other parts of the country to work. So unlike previously where you would have palliative care probably just in the capital and then in Kumasi where I work, there's service spreading out gradually to other regions and to other districts, which is helpful. Then on a local level for the university that's attached to the teaching hospital where I work now has, it's just a course that was awarded to, I say, one of the lecturers through a grant, MasterCard grants that I get to teach on. So every year we have health workers who apply from all over the country and come for training. That comes in 2 packages. There's the basic and then the advanced. And we spend time, I mean, taking them through all aspects of palliative care for them to go and practice. This 2025 would be our 3rd cohort. Then, I mean, for myself, it's still what I've always wanted to do, to be able to integrate palliative care into my surgical practice. And a project I've started working on now is how to be able to step, the cancer patients on my ward back to their communities so that they are close to them, because people travel long distances. I mean, to be within, I should say, my hospital probably provides cancer care for about half of the country. And so people travel hours on end to reach us. And in times of, I mean, at end of life, when they have severe symptoms, they are on our wards and their relatives are so far away from them. And so the thought is to be able to step them down either to their own communities or to, I mean, either to home or to a community close by to them. And so far, what we've realized is because most people around them are afraid of what to do, how to take care of them, and that's why they would rather have them in the teaching hospital. So the aspiration now is to be able to set up a system that would allow these patients to be stepped down either to home or to a community hospital around them. Realize what that needs would be some level of capacity building in those communities and even awareness and sensitization for the staff in the teaching hospital to feel, should I say, comfortable to let them go, because sometimes they also feel like, oh, you're letting someone go and they're not going to be able to get the right service. So currently we are mapping out the patients we have on our wards, where they come from, what their needs are. And we have, I mean, I'm putting together a proposal to look at what the extent of this capacity building would be, how to map people close to their home or to their community. And I'm hoping that eventually, I mean, as things grow with regards to expanding outside, I'll be able to get the support and the funding to make that happen. I know it's a project that the hospital would be interested in because it would help, should I say, decongest us as well, because these cancer patients tend to spend a long time in our wards, and then they take up beds for acute care as well. So that is where I am with my journey in palliative care. Nice to meet you all again, and I wish you the best of the afternoon and the rest of the meeting. Thank you.
Thank you very much, Esther. We wish you well with all of your work and with this wonderful project. Thank you. If you'd like to say a line, you may be interested in the discussion that's going to happen later on this afternoon. Thank you. So, as I said earlier in my introduction, one of the exciting parts for PCW of our conference is to welcome the St. Christopher's students. And we have a number today. You're very welcome, from Mexico, from Bangladesh, and from and Heather. I've got the names of the.
It is a real pleasure to be here, and thank you so much again for the invitation. And the reason I was just going to say a little bit was that this programme that my colleagues are going to talk about, and you'll hear a little bit about from them and from me, is a departure for St. Christopher's from the past. So many of you will know that we used to run something called Multi-Professional Week and then Multi-Professional Academy, and it was always lovely for us, really rich, but we always had a question about the degree to which it really had impact long term. We certainly met individuals that we really liked, respected, worked with in the future, and Rubaiyat's just one good example of that. But I think the pressure that people are on to go back to their areas and put into practice what was really a very high income country model and so on, we never really knew whether it was really having much impact. And so at the end of last year, we did a big rethink, and we decided to start something called the Beacons. And these colleagues are, they're not students, they're our partners, and they are people who are going to help us learn as we hope we will help them in their work. So let me just tell you a tiny bit. This year, we have 6 beacons joining us. We had applications from many more, and we chose really carefully. So we've got beacons coming from Mexico, from Brazil, from France, from Abu Dhabi, Bangladesh, and Hong Kong. And the idea that we have is that we will make it's a corporate endeavour. The connection is between a number of organisations and St. Christopher's, and our idea is that together we will work to try and democratise knowledge and maximise on the many and rich resources that St. Christopher's has that we currently only use for ourselves and for people who find their way to us. So the relationships, I won't go into any details, but the relationships that we want to engage in are highly reciprocal, respectful, supportive, but they are about St. Christopher's learning and maximising on the work and the contribution of the organisations that we're partnering with, as much as us sharing our resources with them. And yesterday, when we met for the first time, we were creating shared ambitions for our network. So the idea is that beacons might work with us anything from a year to 3 years, that they would, we would learn. Your conference today is absolutely at the heart of our ambitions. The idea is that they will take a lot of the products that we have, they'll take products that each other have, they'll localise, contextualise them, and then we will learn globally about how better to democratise knowledge and how to help people grow in their confidence and competence around palliative care through the work of the beacons alongside St. Christopher's. And I just thought I would share some of the ambitions that we generated yesterday. Yesterday was our first day of working together. They only arrived in the UK on Thursday, so they're looking pretty fresh for that. We had a very big day yesterday. But we chose each other because we all have an ambition to use education and training to help dying, death and loss to be more equitable and to be higher quality around the world. So I think that's enough from me. I'm going to hand over to Rubiat to start off. They're under really strict instructions, 5 minutes each. And we just thought that it would be nice to give you a flavour of what they've come from and what they aspire to do. And then if there's any questions, we'd love to take them. Now, I don't think this is working, I'm afraid. So it may be that you need to come around here.
Yeah, that's fine.
So you just need to press the return.
A very good afternoon to everybody. So it's a pleasure to meet you all. Basically, it's my second experience to be with Soho after 2017. So yeah, after Heather, what she said, that we are trying to change ideas. We are trying to go, take in our experience and go forward. Yeah.
Just push through. Yeah. One above.
No.
Do you want me to do it? Do you want me to press do you want to stand and speak?
No, it's fine. But it's
yeah, try this one.
Okay. Yeah, journey of Bangladesh. So as you see, this is the map, and also with the structure of our flag, red inside with green. So basically, the journey starts from 2006 in a very small room, dark room beside the toilet, with the lead of my first mentor, Professor Nizamuddin Ahmed. And he got the idea from his another friend, Dr. Suresh. He's another mentor of us. And he successfully present the compassionate community in Kerala. I don't know, probably everybody knows about that. So we are very inspired about that, and basically this is the university of us. This is used to be the only one medical university of Bangladesh where, from a dark room, this is the center stand up with more than 3,000 square feet, where we have our services, like we have indoor patient, we have outdoor patient, we do home cares. And we also have a special type of care which is called lymphedema care for the people, those are affected with breast cancer. And we have also 24-hour telephone consultation for our patients. So this is a success stories of Bangabandhu Sheikh Mujib Medical University, that educationally, this is the only one MD is developed after 10 years of the establishment from 2015. And today we have at least 30 students on doing the MD curriculum of 5 years, 2 years core training on medicine, and 3 years solid in palliative care. So yeah, this is one of another achievement that we are very what we said, collaborate with St. Christopher's Institute of Palliative Medicine, Kerala, India, and Sanjeevan, that we do some training, and it was appreciated a lot. So, but the interesting thing that during learning in the last 10 years, standing on an institution in palliative care, we realized that our progression is a bit questionable. We are not able to cover a whole bunch of people, because sitting in the university, indoor patient, they're coming and all concentration with them. We started to change our focus to the community more rather than the institute. So we established a group of people that called us palliative care assistant into 2 areas. We choose one slum with the help of World Hospice Palliative Care Alliance. From 2016, it runs for 5 years. And that was a very successful program. We choose people from their own community, just like Sally, I think she already told about Kenya, yeah. So after that, we shifted to a city because that was a complete slum. And that was the intention was that the continuation of palliative care into the community. So after the funding finished by WHPCA. It was taken up their own community, and for the people of Bangladesh, they continue that. And the second one was Narangan City Corporation. It's a small city beside the main Dhaka city. So yeah, this is the same structure is going on there with the help of other collaboration. We have St. Christopher with us. We have IAT Education. We have WHPCA with us, World Hospice Palliative Care Alliance. And very recently, we are working on an online-based education program where people can just learn about palliative care altogether. So these are the pictures you can see. The blue dress are our heart of this program. So we selected 10 people from their own community. Each people are given 10 patients. They go to their houses because, you know, to get the honest belief, these people acting just like more than anything. So yeah, this is about the community-based initiatives in Bangladesh. So we said 2 different names, Compassionate Corail in the slum and Compassionate Narayanganj into the city. Yes, we can talk a lot of our achievements. This is another one. It's a very new start with the government. They, at least after 17 years, try to understand there is something called palliative care. So still, it's not in the mainstream, but they do help us to do a national palliative care guideline. And there is another national palliative care learner's guide for the physician as well. So it's a new start. It's really happy to know. And this is all about collaborators. I can show you that this is all our friends, those helping us to establish palliative care in Bangladesh. So when we talk about opportunities, when we talk about successes, always there is something we want to talk less, that is challenges. So, but I used to try to pick in the first because I'm privileged doing my PhD of challenges of palliative care in Bangladesh. So I'm questioning that the global palliative care mapping, we are still in 3A for the last 70 years. I don't know why. Still trying to cope with the whole situations. We have some other provisions like except this government supported university. We have some other private areas, those do palliative care, but the interesting thing that everything is just in a small geographical area into the city, main city. There is the whole Bangladesh is sitting outside our focus. So, and palliative care is still not in the mainstream of the health policy. And considering a study on 2014, there is still need 600,000 people needs of palliative care in any time, which now I think touched to near about 10,100. Yeah. And, you know, there is lots of myths about palliative care, which we are going through now. And there is also challenges with resources. We talk about a lot. We are not different from other countries like morphine, so I don't want to say all this. So I think this is all about our story. I try to put in a very short time about a glimpse of Bangladesh, and I really want to introduce our chairman, who is sitting behind Professor Motir Rahman. He took all the problems come from Bangladesh, and after Professor Nizamuddin Ahmed, he is the person who is taking care of this center now. So yeah, this is all about. So just last, I just want to share one small experience that it changed my life. So one person came to our center with osteosarcoma. So with a metastasis lung cancer. So osteosarcoma come to the lung. So we have to amputated his hand for a palliative care purpose. So in the next day when he's in the ward, he was crying a lot. And in the fine morning, I asked him, why you are crying today? And he said, this is the side where I used to carry my daughter. And that 6 years old daughter come and said, Dad, you used to have 2 hands, now you have 3 hands. And now I can see we have many hands. So we have big honor as well. So thank you very much for supporting us, and we are trying to.
Brazil. If you want to repeat, you can go back.
Okay. Okay, thank you so much for this opportunity. My name is Amira. I'm a medical doctor. I'm trained in physical medicine and rehab in Brazil and also pain management and public health in South Africa. I'm representing Premier Institute. So some key facts about Brazil, I'm sure most of you must know. Vibrant, incredibly beautiful and diverse country and complex continental proportions. And our health system has made huge progress towards universal health coverage in the last 30 years, in the last 3 decades, and mainly through our primary healthcare program and the family healthcare strategy. One key aspect of our health system is that social participation is a right by law, and this is linked to the history of our health system that was funded immediately when Brazil regained democracy just after military dictatorship. In terms of palliative care, is a context of inequity and bad quality of that, and with some progress. So recently, in 2023, it became an obligatory discipline for medical students, but only for medical students, which also reflects that palliative care is mostly medical centered in Brazil. And also we have a national policy of palliative care approved this year in 2024, and it was a result of a social movement that advocated for this policy. So what we brought in our luggage is quite heavy luggage. It has 20 years of work of a group of healthcare professionals, journalists, musicians, artists committed to improve access to palliative care in Brazil. And our work ranges from micro-level interventions to micro-level interventions. And currently we are focusing developing the CELCA program in Brazil, which was developed and endorsed by specialists, and we are delivering this program for free for public health institutions. And we have the most important universities and palliative care services making this network with us in this program. And we think and we are also directly involved in the leadership of this social movement, responsible for the national policy. And we think it's really valuable to share about the experience of this social movement with the global community, because we never had any funding for this movement. And we literally had only a WhatsApp group, a dream, and connections. So we managed to mobilize and organize thousands of healthcare professionals from all across Brazil to occupy the social participation spaces and approve the national health policy. So it was a very successful experience. So this social participation experience taught us a lot about the power of networking. And then we did this nationally, and the possibility to do it now with global partners give us hope and reignite our enthusiasm. So we hope to work with you, and we hope also to be able to think collectively on how can we transfer the same compassion, the same empathy that we apply in our clinical practice to the care of our planet, and how we are going to respond collective to this emergent crisis. And yes, we need help to improve our research capacity, and we need to start producing more local relevant, cultural relevant research. And as was said here before, it's all about making new friends and making new connections. So thank you very much.
Okay, so hello from Mexico. My name is Beatriz Dorsey, and it's my honor to present the name of my team, which is composed by Marisela Roglin, Bernardo Villacornezo, who has been really key in the development of palliative care, And of course, nevertheless, our nurse, Anisa Alquicira, which I'm really proud of to have here with me today. So Mexico, it's a really complex context. We are part of North America, but we're not really considered North America, but geographically we are. And they want us to do the, like the trade, but they don't consider us for anything else. So we are considered a 4B, but as us being a 4B, we realize that even though we are supposed to be in advanced stage of integration, it's not like that really. And that's a complaint that we have all the time. First of all, because of social determinants of health, most of our care is given just in Central Mexico, living southern Mexico and northern Mexico with really complex situation regarding palliative care. When I was here doing a master's degree in bioethics, I did a paper establishing that one southern state only have 3 pharmacies that can give opioids, 3. And then they have really a wide range of kilometers to do so. So that's why we have over 126 million of persons in Mexico, and we're estimated to have 1.05 centers of palliative care for these persons. For a million, I'm sorry. So that's really nothing for our care. So that's one of the biggest challenges that we've been facing. Even though palliative care was born in 1990 with the work in Guadalajara, Mexico, and also in Mexico City, it's still not a reality. What's going on? And that was the first year that we had morphine for the first time in our country. But it's been 34 years. What's going on now? Well, right now we only have 6 milligrams per capita of morphine usage in our country. So that's nothing. A lot of persons are living and dying with pain. So even though these are statistics, we don't like it. And why is this going on in our country? Basically, our health system is extremely fragmented. What does that mean? We have a public insurance for the military, one for the oil company, because it's nationalized. One for social insurance, one for the really poor persons, and one for the workers, and one for the military, and one for the Navy, isn't it? So it's really fragmentalized, and it makes more challenges about how we're going to provide the care that the people need. So that's one of the first things we have. We have non-government that are trying to be involved as universities, NGOs, associations, and the government. The problem we have is that we have a law since 2009, and then in 2014, and it was revised in 2018, we have something that says mandatory for all persons in Mexico to receive palliative care, as I said before, but it's not a reality. Then what's going on here? So what's going on is that we have a lot of persons who need palliative care and no resources given by the government, obstacles that we all are familiar with. And right now, to introduce our associations, it's CEPAMEX and Fundación COI who came together. I proudly belong to the both of them, but why did we came together? CEPAMEX have a long history in training. A lot of history in doing training for years and years, having made congress and programs for over, the last one that was for nurses. You had over 20,000 nurses, didn't you, Dr. Villa? So they've been doing all these projects to try to bring education. So their core in the heart of CEPAMEX is education. And then we have Fundación COI, who has a little bit more development in training communities. We're making workshops for the people, for them to be more involved in their care and to take care of them, to make communities. And we also have more visibility because it's an NGO. So we came together, and that's how we are here as a beacon. So working like that, as a team, that's something I think is really important for palliative care, isn't it? We have all these barriers, but all our barriers are opportunities. So how can we work on this? Well, policies, we continue working on how to promote our policies. We're not giving up. We need drug access, we need infrastructure, we need implementation. And when you stop for a minute and think about it, what can we do to forward all of this? It's really simple, actually. We can start with education. Because if you start with this, will be the base that will help you continue empowering policies. If you empower and educate your politicians, you educate your regular population. Maybe here they do, but in Mexico, no one goes to the hospital and asks, oh, I want to see a palliative care doctor. No one. But they will ask for the cardiologist, or they will ask for the neurologist, and no one for a palliative care. So education to communities, educations to the students, it will help us to have an impact in policies, implementation, infrastructure, and drug access. So that's why being a beacon for us is so important, because we can tackle this. And why can we do it that way? Well, by bringing beacons closer and making interdisciplinary education accessible, the education will be this engine that will move everything. And we can start having policies and we have implementation, infrastructure and drug access. And we finally can have an impact and not be like 4 years ago. I mean, some work have been done, but we just haven't integrated yet. So that's how we have to work together. And that's why it's so important. And I like the slogan of this year, that it's called Thinking Globally and Acting Locally. And that if we think about it, we were discussing it yesterday, we're saying we are from all around the world, and then we realize we have similar challenges. And then we think globally, and maybe, but we don't have the same resources to do it. But maybe if I listen to my partners in Brazil or my partners in Bangladesh and France, they will give me ideas that I never had before. And maybe even though I will act locally in the end, it will help me develop more ideas. It will help me bring palliative care, the reality that we want in Mexico. And to conclude, I would like to say that there are multiple ways to promote palliative care. But while it is possible to accomplish that objective, which we all know that is really hard to do so, an international collaboration and a global network of education is key, because we all have the same goal and how we're all going to achieve it. So I don't know, I would like to introduce you all to Dr. Bernardo Villa. He's been a key holder in all of this work for the past 20 years, 30 years in Mexico. He was never my professor, but I'm fortunate enough to call him my friend. And I will love to him to say if he want to close. That's why I talk so fast. I want to give him some time. If he want to, of my 5 little minutes. Okay, if he want to add 1 minute of anything, Doctor, you would like to add.
Thank you very much. I'm very happy to be with you today. Yesterday it was a wonderful experience we had with all of us at St. Christopher. We learned a lot, but we are now, I think, more afraid of what we are going to do. Yes, it's very interesting. All this, especially for me, I am a physician, I'm an internist. I studied critical care medicine, and I worked as clinical medical as critical care physician. I was head of a critical care unit for almost 30 years. At the end of this, I was offered a work in a hemodialysis unit, a very big hemodialysis. Well, it was different from the intensive care unit, but the patients, well, were very similar at the end of their life. Some would go outside healthy, but very few of them would really have a good, healthy life. The same thing happens with renal patients. Most of them were at the end of their life. And I started to learn about palliative care. I started to read, and I said, well, why don't we have in Mexico this type of medical assistance for this type of patients? By that time, my friend Mary Aldine, who lived some years before in Scotland, there she went to the university in Scotland and she decided to study palliative care and complementary medicine in palliative care. So when she came back, she called me, she said, look, we did this, and that. So I said, well, this is a solution for my patients in this clinic. So we started to see how we could start an association, a hospice. We saw very many things. So we found some people. One was architect, one was another housewife, different type of personnel interested in association to run a hospice. So we started this association, and we thought we didn't know anything about it. We started to see patients, but we found out that it's very expensive. We didn't have any place to see the patients. We didn't have medicines, but especially we didn't have personnel. All our personnel was knew about palliative care medicine, but they didn't have any knowledge about really what it was. So we found out that first we had to start teaching palliative care. So we organized our first courses in palliative care for nurses, for physicians, and we started to have exits, very people would come in and say, well, I want to learn what you are doing. We want to work in that, and could you show us? So we started to have different courses, short and large courses. And so we found out that our association was converted into educational association. So we have how many years? Well, nearly 20 years working in teaching palliative care. The university was interested in us, and we work now with the National University of Mexico. And so we've grown in palliative care as is the educational institution, and that's our experience. So this meeting with all of you is bringing us lots of enthusiasm, and I'm sure that we will do a lot of things because we need all the physicians, the medical, the nurses, social service, and psychologists. We started with psychologists in palliative care, and well, this is everything. Just let me tell you a very short story.
Just a very short one.
Very short. Last year, at the stand in January, the head of the sindicato goes.
I remember this
Union
union.
Of one of the social services in Mexico called me and told me, look, doctor, we know you make some programs, and would you participate with us? We want to make a course for our nurses. Well, I said, yes, okay. Well, when do you want to start? In a week. So, in a week, I want to know many things about who am I going to teach. Oh, shit, that's very simple. Don't worry, you just work in a program for all this year. Every week you will have. So finally, I started with the program. And when I finished that day, my course, she called me to her office and she said, sit down, please. I said, yes. Well, I want to tell you that, do you know how many students you have? Well, no, I think 50, 30, so there. No. Well, breathe, because there were 6,000 students connected. I said, it's impossible. We did all by virtual systems. It was my first experience. It was wonderful. 4,000 finished the course.
Well done.
That's an experience and experience and the willing coming together and trying to give the best of us. Thank you.
That's so good. So Christopher's done it again. Thank you, Heather. Well done. That's wonderful. It's time for tea break now.